So I've been asked to speak on challenges in genetic counseling in the NGS era. And so you've already been exposed to a large number of cases. And really what I'm going to show you are the experiences that we have when we order these tests and how for some tests you get easy diagnosis, you think of a diagnosis and the diagnosis is confirmed. Whereas in the others, we know that using all these technologies, whether it's microarray, exome, genome sequencing, or whether it's a panel testing, they have their different diagnostic yields. They are very good tests, but yes, it's very important to be able to interpret those tests correctly. I'm not going to go into these because I think that by now all these various technologies would have been covered. But what we are going to talk about are all these limitations that are there in most papers, but we tend to ignore them because we are overawed by the technology and we think that they're going to answer everything that we have in mind. So as Dr. Kaushik in his previous cases very nicely said that it can't be just ordering a test. You have to have a thought process. And even in the era before NGS, we used to make diagnosis. But of course, the diagnostic yields have improved. Nobody is contesting that. But there are many, many issues and we need to think about those and we need to actually know them when we are using this technology. So there are lots of patients with diagnostic odyssey. So if you've done an exome, the diagnosis is confirmed as it is suspected. You've correlated it with a clinical diagnosis. As we saw in my talk on intellectual disability, it's fine. You can do an exome. A diagnosis is confirmed, but not what you had clinically thought of. And you can do an exome and still get no answers or incomplete answers. And those are situations where we need to understand why is it that the exome is not the one-all test. In my mind, even a genome, now that we've started using it and doing it, is not a one-all test because there is a lot we don't understand about the functioning of the human body. And it's all there. We just don't know how to interpret it. So rather than going through this very theoretical sort of a thing, let's start with the cases. So this was a family who came for prenatal testing. And at the outset, we thought it was very simple. The father had unilateral retinoblastoma. And at 4 years, it was operated and he had a scar and he had been asymptomatic thereafter. However, their first child had bilateral retinoblastoma, onset at 9 months of age. So this goes to tell us it's an autosomal dominant retinoblastoma. And we presume that because the younger girl had a very early onset, she had inherited one germline variant, which was heterozygous. And the second hit happened early, and therefore it was an early onset retinoblastoma. Retinoblast RB1 is a tumor suppressor gene. So in the tissue, you need 2 hits for the disease to manifest. Okay. So we sent off and so we also then again reviewed the status. Sequence would pick up 80 to 84% of the variants. Deletion duplications are known in 16 to 20% cases. Oh, did I tell you that there was no report in this? Anyway, and in this case, because there was a positive family history and the lady and that girl had bilateral retinoblastoma, 100% we should have had a RB1 mutation. So you have to have all this information before you send off a test because you are a doctor, you have to be intelligent about what you're sending. So this helps us to first order the appropriate test. So we did 2 things. We did a clinical exome and no variant was identified. And then we wanted to look, for these 20% deletion duplications. So we did a dosage analysis in my hospital and we did not find any answer there also. So then you start thinking, why is it so? Something should have been identified because she was 100% required to have a germline variant. And so then we called in the raw data. So this is the IGV that is generated from the back file. And I don't know whether you've seen these before, but this is the retinoblastoma gene here and here. Look at the 2 panels separately and you see these dark boxes, rectangles. These dark boxes are the exons and these arrows are the introns. Fine. And you see, So whenever, remember they say, you read in a report 100x depth, so much depth. So it is how many times it has been repeated, because it's, it's high throughput. So you have to have a certain depth. So you can see that this, and in an exome, only the exons are covered. So there will be gaps between here where only the exons are covered. So you can see here, this exon is well, oh God, this exon is well covered. This exon is well covered. This is well covered. This exon does not have any coverage. It's missing. And then we go on here. There's no exon. So something seems to have hit it off there. But here, this is well covered. This is well covered. Again, there are two that are not well covered. And then these are well covered. Okay. So when we looked at this, we saw, and then you can count the exons. So we saw that this exon where I've put the red dot is exon 6. And these two exons are 9 and 10. These are not covered in the exome data. So because they're not covered, we don't know what the status is happening. Maybe there's a mutation lying there. So you say it is an inadequately covered RB1 exonic segment. Now, it's not that the exome is bad. Now, in every test, there are these limitations, and it's for us to understand the limitations, look into it, and then address them. So we made a re-evaluation report that so many exons are not well covered, and there were many more beyond, and therefore we need to resequence. So whilst a resequencing was happening, because there was an ongoing pregnancy, we did a Sanger sequencing of just those incompletely covered exons in my hospital, and we identified the mutation, which was a splice site mutation in intron 6 in the RB1 gene. Okay, so this was the region that was not covered. The mutation was lying there, and obviously the exome will come back not negative because it has not sequenced that. So it doesn't know that there is a mismatch there. Is that clear? Anyone not understood? Okay. So therefore the message is, so first you have to review the genetics. You have to be confident that yes, 100% I should find a mutation. It should either be in the MLPA or it should be in the sequence data. So we re-looked at the MLPA. Had we done a mistake in reporting it? No, that was fine. So then you re-look at the exomic data and then identify it. So you just have to be very confident of the first two things, understand that there are caveats in this, and then think before you accept any report at face value. Okay. Now you come on to the second case. Now in this case, there was this child. But that whole region was not covered. So it was missed. Exon array क्यों करोगे? It's the same thing, na?
It is just that it was not covered.
It was just not covered in sequencing. So these things happen. It's not that the lab was bad or this was bad or that was bad.
But is it so that it was not covered in many patients?
So you just know. So this was the original twist capture kit, which was just a poor capture kit, which had just come into the market. So, you know, what do? When they take a blood sample, they take the DNA, they have to capture the exons with something, all right? Because you're only looking at the exons when they're doing that NGS. So there are different kits that are used for capturing the exons. Now, when they capture the exons, obviously, there could be gaps in that. And slowly, as we've identified many such things like that, because we get into every case that we see and we know that there should be a diagnosis. And then we inform the company that these are your missing gaps in your kit. Then they spike it. You know, you'll have the companies coming and tell you, well, we've spiked it. It means that in the missing regions of that original capture kit, now many versions have come. So now they are much better. But there are different companies who use different capture kits. And if anybody is going to start doing it or actually analyze the data themselves, you'll have to understand what are those capture kits. Is it a twist capture kit? Is it an Agilent capture kit? Is it an ID2 capture kit? There's so many capture kits in the market. Okay.
Ideally, we should be covering with a Sanger when there are gaps.
Yeah, you have to cover it. You have to cover it.
What should be the ideal conclusion that for us?
All exons should be covered. ये तो 100x होता है ना exome में, genome में 30x लेते हैं, है ना? Okay. And you don't report it. Sometimes if the region is poorly covered, you get a single variant. You don't report it until you get it in, I think, about 30% of the reads or something. I know in 30% of the reads, you have to get it to be able to report. Okay. So now this was another case where this was a clear-cut osteopetrosis. There was no doubt about it because osteopetrosis is a good clinical diagnosis. Clinically also, there was fractures, decreased vision, developmental delay, recurrent infection, and the x-rays also, I don't have the x-rays, but the x-rays also suggested osteopetrosis. And you can see again, they came in pregnancy, all right? And there was consanguinity. So, and actually, unfortunately, by the time they came in this pregnancy, I didn't draw that, this affected child had died. A clinical exome had been done in 2017. It did not reveal any variant which was consistent with the disease. So that means there were no biallelic variants. This should have been autosomal recessive because it was early onset. But there was a heterozygous missense variant, and this is one of the commonest genes for osteopetrosis, TCI-RG1. But it was a heterozygous variant. There was no second variant. So it did not explain the disease. She's come in pregnancy. Will you do a prenatal diagnosis with this variant? No, no. Why? Yeah, because it has not explained your disease. Yeah, you haven't found the second variant. You have to find the second variant before you do prenatal. So we looked at the data again. The data was good. We did not find any additional thing. So we wondered what had happened. So we had an undiagnosed program happening where we were doing genome sequencing, and we sent off the genome. And in the genome sequencing, we identified a homozygous nonsense variant of unknown significance in this other gene, which is also a gene that causes osteopetrosis. Okay, but it was a nonsense variant, but it was a goose variant. And this was the variant. It was C.54C2A. It was an exon 1. Well, most likely this was the causative variant. We did the segregation and the Sanger validation, but we went back to look at why was it not picked up in the clinical exome? Was this place covered? Was this gene covered?
What is missing in the report? P.16, then position, codon number is missing. Star means the nonsense. It might be something at 17 or 18.
17 or something, yeah. Okay, and then this was segregated in the parents, the allele frequency, so all that workup was done. But when we went back into the data and we looked at the data, this was the proband clinical exome which was done in 2017. This was exon 1. Now this exon 1 was poorly covered. Then remember I told you different capture kits. This was just an exercise we were doing for ourselves. We looked at these various capture kits and we found that in different capture kits, the coverage is very poor. See, look at the 4 reads here. This is enlarged, okay? If I had made it small, it would have been like this. It is just enlarged to count. So this is just covered.
Different patients.
Yeah, these are unrelated. They are all unrelated, okay? They are unrelated. That means across the board, this region is not well covered in an exome because it's a very high GC content region, okay? And very high GC content regions are not well covered. And then how did it come up in the, so this is again an unrelated CREV-V2. So these names that you see here, twist, customized, CREV-V2, etc., are all different capture kits that I was talking about. So we were doing this exercise in-house for us to understand why is it that we are not being able to identify this. And see, this is the exon. It's a big exon, but it's very, very poorly covered everywhere. This was the genome sequencing. Why was there a doubt in genome? A genome is, you don't capture anything because you're doing the whole genome. And if you see the data, if you see the data, I want you to see this. In an exon, over the region of the exon, you'll get this bump. Then it's flat because nothing has been sequenced here. And in the next exon, again, you'll get a bump. Okay, that's an exome sequencing data. This is a genome data. This genome data, you can see here that this genome data is all uniform. You can see it. I'm sorry that this is coming there. I don't know how to remove it. But बाहर क्लिक करने से वो next slide में चला गया. Anyway, so this genome data is very uniform. Even in this genome sequencing, the coverage is poor. Despite that, it got flagged off because now you see here the coverage is poor. This is telling you it's poor coverage, whereas this is otherwise very, very uniform. But it's flagging off in an important gene. And that is why it was reported and also reported saying, please do Sanger sequencing and confirm it. So then it was done. That child had died, remember? I told you by the time the patient came to us. So for all this, we were using that old DNA. We had got the old DNA from the previous company and were doing the subsequent tests on it. And then we tested the parents and you can see that both parents are heterozygous for this. So we now had a diagnosis. This is the gene. The child just happened to be a carrier of another osteopetrosis gene. Fine. So that is why now we do prenatal, you do whatever you want, but never do a prenatal on a heterozygous variant for an autosomal recessive disorder, because that was actually not the causative gene. So where you have a clear clinical diagnosis and there are multiple genes causing the same phenotype, the first test we should do is the exome sequencing. And if you don't find a mutation, then of course you have to go into the details. Do not force a genetic diagnosis. You have to have two variations to be able to confirm that that is the gene and the mutation which is causative of the disease, because giving no diagnosis is better than giving an incorrect diagnosis, especially for prenatal diagnosis, because we have a lot of obstetricians, fetal medicine people here and radiologists. Please be careful for prenatal diagnosis. Okay. Now, this is another disorder. You can see that this child, this is our proband with a family history of epileptic encephalopathy. This child is 4 years old, was good at birth, but just had some developmental delay, seizures, and was hypotonic. So this is the face of the child. There was non-specific ID. We did not recognize it. Okay, there was bracket, though she had many things. She had the constant open mouth. She had a cynophorus, very long eyelashes, and these thick dented lips. She was fairly hirsute, hypotonic, with reflexes that were not elicited. We were not able to give a diagnosis for this girl. So a lot of previous workup had been done. And because she was coarse, an MPS screen had been done, metabolic testing had been done, a microarray had been done, couple karyotype had been done. And in 2018, a clinical exome had been done and no pathogenic variant was identified in her. And so we must have looked at the data, because without that, we don't send a second test. And obviously there was nothing forthcoming. So we know that intellectual disability, now this was non-specific intellectual disability. It appeared syndromic because she looked different from her parents, but we were not able to place a finger on it. Fine. And this is always the thing, they come in an ongoing pregnancy. So we had done a genome sequencing because we had looked at the data of the exome and not found anything. So doing another exome or doing a trio may not have helped us. And here we found a very big deletion of 44,722, 44,722 base pairs in a gene which is called the T-base-CK gene. And it incorporated 3 exons, 20, 21, 4 exons, 20 to 23. And this causes infantile hypotonia with psychomotor retardation and characteristic facies type 3. Fine. So it kind of like fitted our child, but we could not just accept this. You had to go back into data because it's a rare case. We had never seen a patient like that. So you go back into literature and review. There are 33 patients in a paper in 2018 who were reported according to the phenotype that is rare. All the ones which are highlighted in red are present in our patients. So we also know that we don't need to have all the phenotypes. Even having 50% of them, 60% of them is good enough, as long as the key phenotypes are there. So you go into the details. Now, this was what was reported in the papers. These are 2 papers. All of them look similar. You can see that there is a match of the facial phenotype. Yes. So a facial phenotype also was corroborating with what is reported in literature. And we went back into our data also, and we identified another patient who had been identified with this deletion, not with the same, but with another deletion. And that child also looked the same. So these dysmorphisms are not chance happenings. Okay. So doing all this, then, of course, it was segregated in the parents. We used real-time PCR because you're not going to do genome sequencing. So for deletion, you have to set up that real-time PCR and confirm it. So we did that in-house, offered prenatal, and unfortunately for the family, the fetus was affected. So what is the message here? The message is the full workup is required to be done like that. And when you do that full workup, the case then becomes familiar to you. And it was interesting. I was in an Undiagnosed Disease Network International meeting. It was all about trying to diagnose 15 undiagnosed patients who had gone through everything and they didn't have a diagnosis, because there they were doing long read sequencing. And there was one child from Sweden who looked just like our child and just like our child. And we asked them to look at this gene, and there was the mutation. But they had not encountered it. Okay, so they didn't know about it. So that is why it's very important also to work in collaboration for these rare disorders. That's very, very relevant. Okay. This is a story of COVID times. You see what's up there. March 2020. Before 21st March, I think, when everything was shut down, this family had come. They had one child with microcephaly. So she was 6 years old, small head size, severe intellectual disability, behavior abnormalities. And the parents told us that she did not fixate or she did not follow. So she was in very early pregnancy then. So and then an MRI was available. MRI was done in, anyway, the MRI was available. And I cannot remember correctly whether the MRI was done early or as a part of reverse phenotyping. I'm not sure it was done then, because when she came, we sent off the test and suddenly everything shut down. And this MRI, you can showed pachygyria, agyria, and colpocephaly. So you can see here also that there was cerebellar atrophy, and this is the huge colpocephaly. So we had severe ID, behavior issues, visual impairment, severe microcephaly, dysmorphic features, and abnormalities in the MRI. And then a differential diagnosis was drawn up that we could be dealing with one of these possible disorders. And an exome was sent. An exome did not identify anything. And the pregnancy actually continued. There were no scans done, nothing done because of COVID. And then suddenly, for some reason, I kind of contacted that family, where are you? Because we didn't get an answer in our exome. The exome had come back negative. And this was the follow-up. Okay. There was microcephaly. The child had an intrauterine demise at 31 weeks. And we did an autopsy for this child, and the child was identical to the other. So now we knew that this was an autosomal recessive disorder. What had been reported in the exome that had been sent in 2020 was a heterozygous WOOS variant in a gene called ATRIP, which can cause sickle syndrome. So which was within one of the differential diagnoses. But again, there was no second variant. And we found, when we looked at the data, that some of the genes were not well covered, some of the important genes associated with our differentials. And so the company said, okay, we will redo an exome and we'll do a quad exome of both now the children as well as the parents. And then, of course, even more WOOSes came out. So the more you sequence, the more variants of unknown significance come out. So remember that. None of them fitted. So we didn't have an answer. This girl was also taken into the undiagnosed disease program. So she came to us in 2020, and it was only last year, 4 years into, no, so she must have come earlier in 2019, and by the time we started doing things. It was actually a 4 years odyssey. We did an exome, we did a trio exome, we did a quad exome, we got no answers. This was our first case of a whole genome. We were also learning. And in that whole genome, we then got our answer. We got 2 deletions in exon 16 and exon 24 of a gene, which is the TUB-GCP6 gene. Okay. Now, remember, I told you that how you look at the genome, how well the genome is covered. You can see this straight thing. So that's good coverage of the exons as well as the introns. And here were 2 deletions lying. These were the 2 deletions. This was a 700 base pair exonic deletion, which was not going to be picked up by the exome. But this was an 11 base pair deletion, which should have been picked up by the exome, but it missed the eye. It wasn't picked up. Okay, because one, it was heterozygous for a recessive disorder, but it was missed by the exome. Then we put together, we had so much data with us. We put together the genome data of the proband and the exome data of the sibling and the mother and the father. And we also confirmed that these 2 had the same deletion, which was then inherited from the father. This is the 11 base pair deletion. Okay. So it's all been seen in the exome data. But the call was missed. Okay. The call for that 11 base pair deletion was missed. And this is this large 700 base pair deletion, which is also present in the proband and the sibling. It is absent in the father, but inherited from the mother. Ideally, we don't pick up this 700 base pair deletion. It's too big to pick it up in the exome, but there is a special split read application which is used to try and figure out these large deletions, because this is easier in hindsight. Otherwise, a primary diagnosis based on split reads you cannot make, because many such aberrations come up in the exome. So we now have a full diagnosis, which is not because of any of those boost variants, but because of biallelic variants in the TUB-GCP6 gene. And now the family is ready for prenatal. And it is very interesting. Until we found this, I kept telling that family, they were kind of like very simple. I said, don't plan a pregnancy, don't plan a pregnancy. I meant we are not ready for prenatal diagnosis. So you see how important it is not to talk to any families on the mobile phone. You have to call them. You have to call them and speak to them. So then next I get up, when we made this diagnosis, I told them, okay, we've got a diagnosis. Now you can plan a pregnancy. So they planned a pregnancy. But for long I realized, and he told me that now she's confirmed, but then I realized that she hasn't come for a prenatal diagnosis. And somewhere down the line, around 20, 21 weeks, I called up the father. I said, where is your wife? What has happened? He says, बिल्कुल बढ़िया चल रही है pregnancy, ultrasound मेरा बिल्कुल ठीक हो रहा है. तो मैंने कहा वो जो टेस्ट करना था, he says, कौन सा टेस्ट? आपने तो बोला था सब ठीक है, pregnancy plan करो. So he had misunderstood. In my mind, I said, ठीक है, we have a definite diagnosis, we can offer prenatal testing, but they interpreted it differently. So, you know, these are small nuances which are very, very important, and that's why I thought I would share. Finally, we called them and did the prenatal, and luckily the fetus was not affected. Another thing which was a miss in this family was we missed, you know, remember that I had said that the child does not focus and the child does not track. There was actually a pigmentary abnormality in the eye, and because a fundus examination had not been done in all that chaos of COVID and testing and ongoing pregnancy, that was another very, very important clue that we had missed. So that's why it's very important to do all this together and then take forward the testing. 30 weeks. She came only to us at 30 weeks. ना उसके पहले तो आई भी नहीं, ultrasound नहीं हो रहे थे. But it comes up later. Microcephaly is not easy to diagnose in an antenatal scan. For that lady, it was done late because at least in my hospital, all the scans had been stopped at that in the year 2020 till very late. Okay. Yeah. Amniocentesis. So if we had that, sorry. Oh, that's an excellent question. Exon array. I don't have an exon array. So we set this up by real-time PCR in the lab. Okay. So we find real-time, they're very good at real-time PCR. So all copy number variants, whether we find them on the microarray or these large deletions, we set up a real-time PCR. Exon array, we have to send out.
11 base pair
Yeah.
you can do Sanger. No?
Yeah.
But
And
11 base pair
that will come in Sanger, the other one will come in real time.
can-
Real time, ek G uska lekar kar le.
दूसरा कितना base pair है?
It was 700.
700 तो उसके लिए भी you can have that long range PCR and
हाँ.
और नहीं तो real time दो.
So see, there are many techniques. You have to identify what technique your laboratory is good with. There are many techniques, all the techniques that can pick up copy number. You can even look at the microarray. It's a gene. I'm sure that region would be covered in the microarray. So, but you,
base pair cover हो जाएगा 11.
11 नहीं होगा. So you have to go back and see.
Still fighting the homozygous or not.
नहीं 11 base pair वाला मिलेगा.
700 base pair homozygous है.
ये अलग-अलग जगह है. बहुत दूर-दूर है.
हाँ,
बहुत दूर.
22 and 24, 16 and 24. अलग-अलग.
अलग-अलग दूर-दूर है.
तो वो तो अलग-अलग करना पड़ेगा, है ना?
पहले से तो MLPA है.
But MLPA भी है तो आप एक patient के लिए MLPA मंगाओ. It's more cost effective to do. I don't know. We are very comfortable with the real.
होगा भी नहीं.
हाँ, होगा भी नहीं. Plus, even for one patient to get that expensive 50,000 का MLPA and then not have another patient for, है ना? Okay. Now, so this is actually about an eagle eye to look beyond the ordinary. And I have to give credit to somebody when I talk about this case. So this was a child who came. They actually brought this child. The child was okay, but she was short. She looked different. And she had these skeletal anomalies. Okay, she looked very different from the parents. Intellectually, she was fine. So she had what we call a clinical diagnosis of Robinow syndrome. And we made a diagnosis of Robinow syndrome and we sent off the data. Actually, at that point in time, we had a project which was going on where they were doing trio exome sequencing. So here, when we were examining, we also noted that the father and his other daughter, she was the older daughter, sorry, this should have been like this, were short, but she was looking fine. She and she were very different to look at, and they had these skeletal abnormalities. You can see. So the father also had this terminal sort of brachydactyly, so did the girl. And so within that project, we sent off a quad exome sequencing. Now, what came back to us was this, a BMP2 heterozygous variant. This BMP2 heterozygous variant, it's like a brachydactyly phenotype, but it did not explain the phenotype of this child. So we were wondering what it is. And one of my residents told me, she says, ma'am, I'm 100% sure we were not doing, we hadn't done the primary analysis, that they started the quad exome from the older child. They found this variant, and because the phenotypes were okay, nobody looks very deep into the phenotype. They found this and they issued the report. So I thought it was brilliant. So she says, let's look at the data and start looking at this child for our Robinow gene. And that is exactly what happened. And it was actually the truth. So there were two disorders in this family. One was the non-specific brachydactyly, which was not, and short stature, which was not bothering the family. But additionally, this child had a de novo variant in the DVL1 gene, which was causative of Robinow syndrome. It was not present in the data of this child. All right, it was only present in the data. So because we had a quad exome, it was very easy for us that she was a de novo heterozygous variant, and those variants were not present in either the mother, father, or the older sibling. So, a dominant Robin. Okay. So that is why, again, we come back to the case that no technology, this was a quad exome, what more can you want? But no technology works until you have a good phenotype and you know what you're looking for. So that's dual diagnosis. This is another interesting family. This girl has galactosemia. She was diagnosed very early at 6 weeks of age. We did a biochemical diagnosis, tested the metabolites, tested the enzyme, and in that era, there was Sanger sequencing of the GALT gene, and the Sanger sequencing had identified 2 variants. I'm not sure whether in that era we ever thought of anything called a variant of unknown significance. In Sanger, there was no variant of unknown significance. I think the variants were just reported. Okay, they looked into ClinVar and everything, but they were reported because you had the rest of your phenotype. Now, but you had the biochemical phenotype. No, the galactose was high, the galactose 1-phosphate was high, and the GALT enzyme was low. I mean, we do it like that. Now, she was 8 years old. The parents were consanguineous, so they came back that we please do our carrier screening. We want, they didn't say carrier screening. We want to plan another pregnancy. Are we at risk for any other disorder beyond galactose? So because they were consanguineous, we offered expanded carrier screening to them. And look what came out in this report. There were so these are genes, 1, 2, 3, 4 genes. We can disregard this because in carrier screening, we don't take into account, no, we can't disregard this. This is the galactosemia gene. There was one more Woos gene, which I disregarded. But there were 3 genes, Ehlers-Danlos, Xeroderma pigmentosa, primary hyperoxaluria, and galactosemia. And so we knew that their child had galactosemia, so this was relevant. And then there were these other disorders which were very significant because they were likely pathogenic and pathogenic variants. Then we went into the data to look, are any of these genes linked? That means, are they very close to each other? And because they are consanguineous, they have a chance of being inherited together. And we found that the primary hyperoxaluria and the GALT gene are closely linked, and they would always be inherited en bloc for this family. And they would be causative of disease because the parents are both carriers for this. Then we went and tested their child. And for GALT, we knew that she already had been tested and she was negative for everything. Matlab, she was positive, but this was a recessive disorder. But she was homozygous for the primary hyperoxaluria gene. So you remember I told you that they are linked. And then we went into the history. I started asking the parents. She was 8-9 years old, and we know primary hyperoxaluria will manifest later. And they did tell me, she says, a few years ago on a routine examination, she had some kidney issues in the blood and the urine test. She was reviewed by a pediatric nephrologist, and it was not very clear because they did not seem to be fitting into galactosemia. But usume bola that, well, she's got galactosemia, otherwise she's doing well. So maybe it could be linked to galactosemia, and we'll just keep you on the follow-up. But they were really the early manifestations of primary hyperoxaluria. So now, unfortunately for this girl, whilst her galactosemia is very well managed and she's fine and everything, she's got an additional disorder of primary hyperoxaluria. And how are we going to counsel this family? So this is a question I'm going to leave for the residents of genetics. You have 4 genes, out of which 2 genes are closely linked. Yeah, they have linkage disequilibrium. What sort of counseling are you going to give this family for the next pregnancy?
We can offer for XC or OVA.
They want to go, but how will you guarantee कि पहले तो आप counsel करोगे ना कि risk कितना है? I don't agree at all. That's bad answer.
When I do.
It is not our choice what they want to do. It is our duty to tell them what the risks are. And it is for them to choose whether they want to test, whether they want to do a prenatal, a CVS and a prenatal, whether they want to do a PGTM or they want to do a gametometry. It has to come in that order. Okay. But you have to be, so if you give me that answer, I'll say you just don't want to use your brains to find out what the risk is in counseling this family. You have to give them what is the risk of disease and what is the chance that the fetus is not going to be affected. Okay.
ये तो calculate करो.
हाँ, तभी तो मैंने सारे senior geneticists को बोला है. Senior क्या? Senior, junior सब करो. All genetic trainees.
एक disorder के लिए 25%.
Okay. So now here we know all this who's thing. We've talked about it enough. This is another common scenario. Now this was a child, again in the nursery, good weight baby. No reason to get into the nursery. Had perinatal asphyxia, we don't know why. Seizures at 6 hours, infantile spasm onset at 4 months, severe global developmental delay and spasticity. So they will definitely come to you for counseling for the next pregnancy because this child is so severely affected. You go into the details, day 6 MRI, diffuse cerebral edema, hyperintensities and corpus callosum, very non-specific. It could be because of one of so many causes. 5 months, diffuse cerebral atrophy, well-defined areas of encephalomalacia. Bera poor waveform, metabolic profile was normal, which means ammonia, lactate, homocysteine, TMS. That's the maximum we do. And the VEP was normal. So your first diagnosis remains cerebral palsy, but it could also be, because where you have so much of encephalomalacia and your brain MRI looks like it's been all eaten up. There's hardly any bit of the brain parenchyma left, a molybdenum cofactor and a sulfite oxidase. And why do I say that? Because I see that it was a good weight baby, a 2.65 kilo baby who never had a very good outcome. So for this, a whole exome sequencing was sent. And in one of the genes, we got a boost variant for an autosomal dominant disorder. So then you go into the details. Is it present in literature? Is it matching? Is it not matching? Now look at this. It's actually, they had no business to report it because nothing is matching. It's reported in normal population from South Asia. 5 individuals for such a rare disease gene to be reported as heterozygous for the same variant. Obviously, it is not disease causing. Okay. And then, of course, to be very sure, but because it was associated with a disorder, they would just report it. But what I'm trying to get to you is don't take everything that is reported. You have to go into all this. Okay. Whilst your phenotype may be partially matching, if it's present in the normal population, if none of the criteria are matching, you will not use this. And when we segregated it, it was segregated in the parents and there was, the father was heterozygous and the mother was also heterozygous, not heterozygous. So that's how but there was no reason for it to be reported. Once it gets reported, you have to do that whole drama. This was a consanguineous family and it was terminated at 20 weeks for radial ray defects, cardiac anomaly, malrotated gut. A fetal autopsy had been performed and it confirmed everything. You can see the details of the autopsy here. This was the radial ray defect. And so, like you all right, autopsies, a whole lot of differential diagnosis was made. Now, these are important disorders because these are autosomal recessive disorders. And heterozygous variant, now this had been done, a mitomycin C. So this is the breakage study, which is done in a blood sample. And it's a stress test. And if there are increased breakages compared to a normal control, you know that you are dealing with a chromosomal breakage disorder, which in this case would be a Fanconi anemia because that fitted well with the phenotype. Now again here, a heterozygous variant at +7 was reported in a Fanconi anemia gene. FANC-A is one of the genes for Fanconi anemia. But you can see that it was previously reported as a benign variant and that it had no business to be here. But anyway, it was reported. But then the child had the disorder. We had a good phenotype. We had a functional here, which was supporting us. We had a functional of a bracket study. So again, we looked at the data. So now you all have understood this is 1 exon, this is 2 exon. Look at the fetus, not covered. And these are normal controls where it's covered. Okay. So this child actually had a homozygous deletion in another gene, FANC-CCG, in a FANC-C gene, which was causing a kind of Fanconi anemia, which was present in, which had presented in prenatal life. So now you had a diagnosis, you would segregate, you would do all steps. But now because you had a chromosomal bracket study, you knew that your patient had Fanconi. Otherwise, it could be whole Toram, it could be one of so many other things where you may just have given up and said, okay, I don't want to look at the data because I don't know what my patient had. So it's like somebody was saying, should we just do an exome for a diagnosis, which is so easy? Like we saw an MPS 4 child in the OPD today. Should we just do an exome? No, you don't do that. You don't know what variant is going to come up. And my last case is related to that. This we'll leave. And okay, so this is my second last case in case you all are getting bored, and then we'll come to the last case. So this is a family, 2 pregnancies monitored in my hospital with agenesis of corpus callosum. And we did an autopsy in the first, we did an exome in the first, we did not find any answer. Again, in the second, we did an autopsy, we did an exome, we clubbed both the exomes together, we did the parents, we did everything, but we didn't get an answer. So we counseled them like that. We don't have a genomic diagnosis. You'll have to follow up on ultrasound. We don't know what is causing this phenotype because agenesis of corpus callosum is such a kind of like broad phenotype. It could be because of one of so many things. Okay, so these are the ultrasound findings that were done. Until 3 years after the second pregnancy was discontinued, a previously reported gene and the phenotype this had been reported with was NBIA, the neuronal brain iron group of disorders. Okay. And now it was reported with a pontocerebellar hypoplasia. And they reported a homozygous variant in this COSY gene. So we have a little eye for endogamy. We have a lot of endogamous population in northern India, a specific population, and we have an eye for that population. And we realized, well, this is the same population. It's a homozygous variant. So we went back into our data. No, we didn't do that. We have a data set of most of the clinical genetic centers where some sort of data is put up of normal reported WUSs. And within that, there was a patient of Qlik's, which was there with the same mutation. So we contacted Qlik and we got that patient and did the sequencing and took the phenotype, and the phenotype was of pontocerebellar hypoplasia. We went back into our database and doing all this, look at the number of patients that we were able to collect. And this is just from 2 centers. We did ask the other centers, but just verbally. And we got 9 patients from 5 families, all of them having homozygous, and we didn't do any testing. We looked at their old genomic data because they had undergone sequencing. We looked at that old genomic data and we identified the same variant. Okay, so this is a pontocerebellar hypoplasia. This was the largest series that was written. The defining paper was just, I think there were 2 patients. Okay, so ours was the largest series that we wrote up. And this is the patient from here, Dr. Qlik's patient. So this child was born, and here you can see, look at this. So this kind of like helped us because this, when we went back to the ultrasound images that I showed you, it was not possible to look at the pons was appearing normal. So on the ultrasound, it comes up later. On the ultrasound, we just got some arthrogryposis and agenesis of the corpus callosum, which you can see here as well. Okay, so this is again You don't have a diagnosis, you don't have a diagnosis, but you follow up, and you may be rewarded. And this is the last patient. At the outset, a very easy patient. Mucopolysaccharidosis type 2. All tests were done, was on enzyme replacement therapy. Okay, so you can see that the enzyme level is low. It was done in 2017. The other, whenever we do one sulfatase for MPS 2, you test for other sulfate enzymes because there's another disorder called multiple sulfatase deficiency. If you don't test for them, you can mistake it. Okay. Anyway, so he was an MPS 2, a repeat test was done, but we did not find any mutation in this child. So the sequencing of the gene was done here. There was no pathogenic variant. The MLPA was done by us. There was no deletion or duplication. Okay. And then a whole genome sequencing was sent out from here where C.880 minus 72. Okay. Minus 72. A to G hemizygous variant. So there was a substitution, and just read all this for the description. And this was also inherited from the mother. But you cannot ascertain this to the disease. Minus 72, you have to prove it. Anyway, they had come for a prenatal. And so in the prenatal, then from here, Dr. Shubha sent the patient to Delhi because it was imperative that we directly take the CDS. So we did the proband testing again in-house, just to be very, very sure, because every lab method is different. Okay, so that had been done at another lab. So we did the proband, we did the mother in the leukocytes, in the plasma. We did the CDS, and the CDS of a normal. So the CDS came slightly low. Okay, it was at the upper end of the affected range, but it could be a carrier. It was not in the affected range. Whilst we did do this, but it has no meaning. Even whilst I did it, I don't know why I did it, but I'm very sure it has no meaning because there is nowhere that we have confirmed that this is causative. We did go on and we did look that, well, the child was not of the at-risk category, just for us to be sure, because the enzyme level had come a little more. And this is only to show you that the enzyme in a serious sample can never be 100%. You have to correlate an enzyme with a mutation study. But where you don't have the mutation study, we counseled the family like this, that to the best of our ability, the child is not affected. Okay. And we are doing RNA studies, and while even I'm learning what all these RNA studies are and doing them in my hospital, but as of now, we still haven't proved. And we believe that that minus 72 variant is not the actual variant. It is not the actual variant because we have done all this work, and exon 8 seems to be skipped while it's too far away. Exon 7 needs to be skipped. Exon 8 may also be skipped. So it really hasn't proved to us that, yes, this is the causative mutation. So I do conclude with this, but I hope I've been able to show you that it has to start with the patient. You have to have good communication. It is not for us to decide anything. It is for us not to confuse the family, but to explain to them simply what are the limitations of the test. They are paying a lot for these tests and they think that they will get a final answer. There are challenges of interpreting. You have to do phenotype, phenotype, phenotype. You can't do, can I send a NGS for microcephaly? Lots of people call me and ask me, ma'am, I have a child with microcephaly. Can I send a NGS? I don't even know what to answer. I say no, but you have to examine the child. Yeah, you use your HPO terms. If you get a mutation in a gene that is not what you had thought it would be, reverse phenotyping again becomes very important. So thank you so much.